Good afternoon. Welcome to Bariatric Friday. Today is May 6, 2022. My name is Kemal Erkan. I'm the chairman of American Surgery Center, and I'm here with Dr. Isaias Irgau. Dr. Irgau, how are you doing?
I'm doing very well, Kemal. Thank you for having me on another Bariatric Friday. It's great to be here.
It's always good to have you. And so we are gonna continue our discussion from last week. So this is our new cycle, so the fourth one. I do want to just send one link to our people, and many of them already have it, but sometimes they kind of just expect me to send it. So that way they don't blame me. And here's the second one. All right. So this is, again, American Surgery Center and CHRIAS, and we are Delaware's #1 bariatric weight loss surgery center. The weight loss is a very specific surgery, and the expertise is expertise in surgery is always important, but when it's weight loss, the program itself from the beginning to the end, it's even more crucial and important. So, and we have the best surgeons in Delaware, maybe in the United States. So, Dr. Erkan, you are one of those. So, if you can briefly introduce yourself, in case though there may be some people who didn't watch this episode before.
Thank you, Kemal. I appreciate it. My name is Dr. Irgau. I am the president of CHRIAS, or Christiana Institute of Advanced Surgery. My specialty is weight loss surgery or bariatric surgery, and I have been performing bariatric surgery now for 20 years. In fact, with my colleagues at CHRIAS, we are by far the most experienced group when it comes to weight loss surgery in our area. We've actually established and set up centers of excellence for weight loss surgery in many of the health systems in our area, including hospitals. And more recently, of course, the American Surgery Center, which is one of the few ambulatory surgery centers in the country that has been designated as a center of excellence for bariatric surgery. And I'm very, very proud to be associated with you, Kemal, in setting up the American Surgery Center.
Thank you. So, Dr. Irgau, we did have one of our meetings from the Accountable Care Organization. Every Thursday we meet, but last night we had a guest speaker from one of our insurance companies, and the presentation was extremely well, and you were there as well. And the stigma, it's just in my head. It's just that I'm hearing it and hearing that. I can't just get it out of my head. Like when we are treating disease and when you have to deal with stigma, can you just maybe elaborate that, give a little bit background and just explain what we meant last night?
Absolutely. I mean, there is clearly this stigma associated with obesity, where patients who suffer from obesity are clearly discriminated in many ways, right? Even as the doctor was presenting yesterday, even when it comes to treating any type of illness, there is data that shows that healthcare professionals spend less time when patients are obese when taking care of them. But more importantly, one thing that was really striking, Kemal, is this is something that you and I have seen before, is that there are insurance plans in place that are actually excluding bariatric coverage from their services, right? So here is a person who is a body mass index of 58, let's say, right? Which is extremely high weight. It could be a young mother in her mid-40s who has struggled with weight most of her life. She has tried every known diet in the past, right? And yet the weight had continued to go up until she has reached this stage where the weight is now in the 350, 360 range. And, with her height, that gives her a body mass index in the mid 50s. She works in a big company. That big company has a health plan coverage that excludes bariatric surgery, which means that if she's seeking bariatric surgery to lose weight and become healthy, she cannot have it unless she can pay for it by herself. And yet this is perfectly acceptable. Now, if a person had a different illness, if they had cancer, for instance, no insurance plan would ever be allowed to carve out cancer and not being covered as a service, right? And yet when it comes to treatment of obesity, it is something that is accepted. And that shows you how deeply entrenched is this stigma of obesity in our society. And that is really why we are struggling to increase the number of people actually who could be covered with bariatric surgery. Bariatric surgery is the most effective treatment we have right now for people who suffer from extreme obesity, from morbid obesity. All other treatments have shown failures. Bariatric surgery is the only one that has demonstrated clear success in the long term. And there is very, very few areas in medicine that have been studied as closely as bariatric surgery, just because doctors had to be absolutely sure they showed really the benefit that this treatment offers, because that's the standard that they've been expected to uphold compared to other diseases.
And one of the other things that he mentioned, now we are a surgical group and surgical program, but we are not just looking at the treatment of morbid obesity from the surgical side of it, but even just treating the morbid obesity from non-surgical side of it. So the stigma actually comes even into the picture more and more when it's non-surgical. So they're not touching the topic. Like, well, so the patient is there, and then you are morbidly obese. Well, you're on your own. Kind of like, well, I'm not going to ask you a question because I may hurt your feelings, but your BMI is 50. That's okay, no problem. So, but there are some medications that's available. I don't want to tell them because I may hurt your feelings. That's not what medicine is. And also that society should be, by now, should be a lot better in terms of understanding what's happening to other people when they are not treated. Like, just imagine if someone's suffering from diabetes and they're refusing the treatment, and we are going out of our way to help people, someone who has kidney failure, someone has hypertension, like if someone's blood pressure is 190 over 110, what would you do? Like, really, Dr. Irgau, what would you do?
Absolutely. I mean, you cannot let the patient walk out of the door without really that being addressed. And yet, when it comes to obesity, although we know for sure now, and we've established is that it is a disease, this approach is not there, right? And the greatest concern here is that obesity is actually the fastest growing epidemic we have in our society right now, right? We have reached a stage which a third of the population of the United States are actually obese, which means they have a body mass index greater than 30, right? And once you reach that stage, the risks of developing type 2 diabetes, high blood pressure, sleep apnea, many other illnesses increase, right? And unless you address that root cause of obesity, then you're not going to be able to really catch up with those illnesses that no matter how much medications you throw at the patient. So addressing obesity as a disease is really a responsibility of healthcare workers, and health plans have a responsibility to provide adequate coverage. Patients should not be worrying about whether they will have coverage or not when they seek bariatric surgery when their body mass index is 50 or greater.
So I know you don't like giving names, but and opposite of you, I do like giving names. So Walmart is the one that's not. I'm just going to check something with Walmart. They're not providing coverage for. Let's see how long it takes for Anthony to just give me a warning. they are not giving bariatric coverage. So now Walmart is known as, what do we know them as? Like, they are the biggest, let me just get to Wikipedia so then we are kind of like objective. So this is a company that is, the revenue is 572 billion. It's, I think 80% of Turkey, the country, Turkey.
Amazing.
Right? The revenue side. The operating income is 26 billion. Shame on them. Shame. So, but we are letting these things happen, and then shame on us.
Right.
So, okay. Now, well, we have some discussions to have today. Our topic is, what can someone expect after bariatric surgery? And I don't know if I have my pictures that were updated, and so I hear people giggling outside of my office. I think they like my cartoons. So Katrina, do you remember Katrina?
Oh yeah.
Okay, so I'm going to remind you a little bit, because you haven't seen her since last week. Katrina is a 37-year-old, BMI 47, and she doesn't have diabetes. So we just want to continue from her point of view. What can she expect immediately after bariatric surgery? And I have all of her information here. So since now I'm going to be her, if you want to ask me anything, feel free.
Absolutely. So no, I think that is actually a fairly common scenario, Kemal. And we can talk about the first 4 weeks after surgery in terms of different aspects of her life. And because these are very similar for your other example as well, the one that's going to have gastric bypass, if you want to bring that other patient as well, then I can talk about both of them with regards to recovery of surgery.
So yeah, I can do that. but while you are talking, I'll try to get them together. So go ahead.
So essentially, taking into consideration the two most common procedures that we do, which is one is the gastric bypass, the other one is the gastric sleeve or sleeve gastrectomy. If both of our patients have had that, what would they expect, right? Well, overall, essentially, life is going to be much better, right? There is going to be fairly rapid weight loss soon after surgery that they are going to actually feel it, and that will have an impact in a beneficial way, obviously, on them, right? The first 4 weeks, different aspects of their life. For instance, let's start with diet. What will they expect? Well, actually, there is a fairly well structured diet progression in our program, right? That we instruct patients to adhere to. For instance, in the first 2 weeks, they are going to be on a liquid diet, right? And the reason for that is because their digestive system that has been operated on is in a healing phase at that time. And we want that to support that healing by having really softer things go into their stomach and then into their intestine as well, right? And liquid is the best thing to do in that stage. Now, what is the definition of liquid? Well, anything that they are able to drink with a straw is defined as liquid. So it could be thin, it could be thick, but that's how they would be essential, right? And our dietitians, they will give them different examples of the liquids they can have. Of course, water is the foundation, but they can have protein drinks, they can have soups, they can have even things like sugar-free Jello at this stage. The main goal, obviously, at this stage is that they stay hydrated. They have enough fluids getting in, right? And why is that important, Kemal? This is important because they cannot afford to become thirsty because they cannot chase thirst quickly enough to address that issue. And the reason for that is because they cannot drink a lot of water at once. Their stomach is a lot smaller physically, so they have to take very small sips at one time. So if they allow themselves to become very thirsty and then they try to drink a lot of water at once, they cannot do that. So they have to proactively prevent thirst by taking little sips frequently. One of the ways I explain this to patients is I tell them, look, if you're not asleep, if you're not talking, you are sipping water, right? Which means they have to have some type of fluid with them at all time so that they are drinking frequently. And another reason why hydration is important right now is because they're not eating food, right? Well, when we eat food in the normal situation, Kemal, because the food has a large content of water in it, we're actually getting hydrated as well when we're eating. So if you're not eating, you are missing that great proportion of hydration that you get from your food. So another important reason why they have to really be focused on hydration. So hydration is very important. So the first 2 weeks is going to be liquids only, right? What happens the next 2 weeks? The next 2 weeks, they go into a phase of what we call pureed diet or mushed up food, right? And what's the definition of that? Well, the definition of pureed food for our purposes will be any food that does not require chewing, right? So if you make sure that it's mashed up, if you use a blender, if you use a fork to really mash it very, very nicely, and then you're able to eat it. And one way to explain this to the patients, Kemal, I tell patients that they have to pretend as if they have no teeth. So they are looking at food in front of them and they say themselves, can I eat this food if I have no teeth? And if the answer to that is yes, then they can eat it. If the answer to that is no, then they cannot have it. It is very important they adhere to that. So first 2 weeks, liquids only. The second 2 weeks is going to be a pureed diet. So now we are 4 weeks after surgery. And at that time, they will start introducing chewable food, food that they will be able to chew. But the transition, again, should not be abrupt. They're not going from pureed diet immediately to chewable food only. They will be introducing chewable food very, very gradually. The good news, Kemal, is that at this stage, patients are not going to be feeling hungry, right? So the issue of hunger, of wanting to eat a lot of food, is not there at all. And the vast majority of patients actually adhere to this progression of diet perfectly without too much of a problem. Now, there are some challenges at this stage. For instance, one of the things that happens because of bariatric surgery is there is a change in the sense of taste and smell, right? So patients will find that certain smells or tastes of foods will be different. Maybe certain things that they liked before, they're not going to care for at all this time, or certain things that they didn't like before may be okay at this stage. So there's going to be a trial and error thing where they experiment different types of tastes before really they can see whether they like it or not. So one of the advices I give to patients at this stage is, if you're eating something you haven't had since surgery, before you make a meal out of it, just try a little bit and see how it settles down. Wait 5-10 minutes. And if it goes down fine and it settles down okay, then they can have a meal out of it. Now, this issue of different taste and different smell is temporary. It actually goes away after a few weeks to a few months. But at the beginning, most patients will experience that. So as far as diet is concerned, our program goes by this progression, Kemal, which works very, very well in protecting the healing of the digestive system, and patients adhere to it very, very well.
So I was able to bring that other patient next to the younger one. So, so after watching our last video and how unhappy you were, now I have fruit table and fruit plate.
Okay. Thank you. I appreciate that.
Now, this patient is a 62-year-old, BMI 42, with heartburns, and now 2 different surgeries. The younger patient, patient Katrina, is getting gastric sleeve. and Samantha is getting the bypass. But
Yes.
what I'm hearing from you is, in terms of the first 4 weeks, what they do is the same.
Very, very much, very much.
They eat almost a liquid diet in the first
2 weeks.
2 weeks,
Yeah.
and then the next 2 weeks is anything that they can not chewable, right?
So anything that doesn't require chewing. So it's a puree, it's a mash diet. Yeah. So they have to pretend as if they have no teeth.
Okay, and so that limits the total amount of
Yes.
food
Yes.
or liquid that we would have, like that kind of limits that.
Absolutely, absolutely, absolutely.
And it's kind of like it's 4 weeks. It's not a lot of, I mean, it's not huge. It's not too long, but it's still kind of like mentally they have to prepare for that.
Absolutely, absolutely. So
in that time, I see you, like, I mean, since I'm both patients, so I have like personality disorder, so so I can be either of them. So in that 4 weeks, when am I going to see you, or how often am I going to see you?
So you will see me in the 2 weeks after surgery will be the first visit. That's the first post-surgery visit, right? And at that time, you will be progressing from the liquid diet to the pureed diet. So most often patients will be just seeing me as they are finishing their liquid diet phase, and then they will go on to the pureed diet, which is an important point you brought here, Kemal, is that actually, if you think about it, a month sounds like a long time with that drastically different diet. But the great thing is that patients actually adapt well because the surgery has drastically changed the way they feel hunger, right? That's a very, very important point, right? In a normal situation without having had surgery, for a person to just be on liquids would be a struggle, right? And if it, in fact, it is. Remember when we do that special diet before surgery, there is a lot more struggle. But after surgery, actually, they don't struggle quite as much because the sense of hunger, the sense of urgency for getting food is not there. So patients adapt pretty well. It is actually very important for patients to adhere to this, because there is a very important reason why we want to do that. Particularly, we don't want patients to eat chewable food in this stage. And why is that important? Well, because when patients eat chewable food, the chances for them to swallow something that hasn't been chewed very well are very high, right? And if there is a big portion of food that enters their healing stomach, the chances for that stomach to be damaged or even to be disrupted are high, and that can lead to leaks. And leaks are one of the most serious complications of surgery. And as we talked before, the incidence of leaks in our program is extremely low. And one of the reasons it's low is because we focus on prevention. And one of the preventative methods is to educate patients about sticking to those diets right after surgery.
So I just kind of like, if you think about number of people who have different illnesses, diabetes at 83, 83% of the people who are going to get resolution on their diabetes, 82% of the people that are going to get their cardiovascular issues, reflux, 72 to 98%. Sleep apnea, 74 to 98%. So the chance of Katrina and Samantha, when would they expect those types of changes?
So it's very interesting. So let's look at type 2 diabetes and blood pressure first, okay? Both conditions will actually show marked improvement very early after surgery. Remember, in the first month or so after surgery, there's actually a fairly rapid weight loss. Patients can expect up to 17 to 20% of their excess weight to be gone in that first month. And for most patients, that means anywhere between 10 to 30 pounds. And for patients who start at very high weights, it could be even up to 50 pounds. And with that drastic weight loss, there is actually drastic improvement in those comorbidities. And how is that reflected? Well, for instance, patients who are on blood pressure medications, they may find that their blood pressure is improving to the extent that the medications that they are taking are too strong. And they may start experiencing dizziness. So patients will call us and say, oh, I felt dizzy when I was trying to get up from my chair. And the first question I ask them is, oh, are you taking blood pressure medication? And the answer very often will be yes. And then I will tell them, your blood pressure is getting so much better that you may not need those medications. And we're talking about, a week, 2 weeks after surgery, right? And very often I direct them to their primary care doctor so they can talk to their primary care doctor about adjusting their medications. Well, how about type 2 diabetes? Similarly, but the actual improvement in type 2 diabetes could be even more drastic for the gastric bypass patients, as we talked last time, right? In fact, there are some patients who experience total resolution of type 2 diabetes immediately after surgery. So we could be checking their blood sugar in the recovery area or the next day at home, and it may be normal, and they may not require any medications at all. Now, this does not happen with every patient who has gastric bypass, but it can happen in enough patients to show how powerful this procedure is for type 2 diabetes. Well, how about for Catherine, the gastric sleeve patient? Well, if she had type 2 diabetes, and I know she doesn't, but if she had type 2 diabetes, she would see an improvement also as she's losing weight rapidly. And in her case, there will be a need to adjust the medication for diabetes as well. In the long term, the numbers that you quoted are absolutely right. It could be total resolution of type 2 diabetes or improvement in both cases within months after surgery.
So now the nutritionist, would I still need to see them? Because one of them was a Medicaid patient, and then I had to be with the nutritionist for like 6 consecutive months. Now, do I still need to have that?
You do. First of all, because even when we talk about the progression of diet, Kemal, from the liquid to the pureed, the actual nitty-gritty of what that means, what kind of foods, right, means is important. But more importantly, when we go to the chewable food, right, there is going to be a priority of foods that we want both patients to have, right? We want them to make sure that they have protein as their first choice. We want to make sure that they have fruits and vegetables, and then carbs should be the last option. Now, why is that? Well, because the amount of food that both patients will be eating now in terms of quantity is going to be drastically reduced. So, but the actual amount of protein that each one of them needs as a matter of necessity will still be there, right? Most patients will need 60 to 70 to 80 grams of protein a day. Now, when you're eating a lot of food normally, you don't worry about how much protein you have, because most foods will have enough protein that with that great quantity of food that you're eating, you will be assured that you will have enough protein. But when you drastically reduce the total amount of food you have, suddenly how much protein you have in that food becomes important if you are to maintain that requirement on a daily basis. So the dietitians are very important. The nutritionists are very important in guiding, even though there has been a lot of education before. So we absolutely recommend that patients see the nutritionist in the first month after surgery.
They are available through telemedicine, so right? So that shouldn't be a huge problem anymore.
Absolutely. Yeah, telemedicine is one of the greatest things that has happened, obviously, to us in terms of really facilitating care. One of the silver linings of the pandemic, as you say very often, because then the issue of scheduling, the issue of taking time off, all those things are eased up by telemedicine. But these critical encounters with the other members of the multidisciplinary team become much easier to do.
I'll do a better image next time with this one. This is from last night's presentation, but there are 13 cancer types associated with overweight and obesity, and one of these patients may be dealing with these. In terms of the cancer prevention, what are the, after the surgery, what would that be?
So what we have found out, Kemal, is that, as you said, as it was presented last night as well, is that there is a very, very high association between many types of cancers and obesity, right? We don't still understand the causal relationship, but the association is there, right, from epidemiological studies, which means that the higher the body mass index of the person, the higher the risk for certain cancers. And by reducing the body mass index, by getting that person to lose weight, we're automatically reducing their risk for getting certain cancers. And that's the most important message we have, obviously, as far as cancer and obesity is concerned.
So but it's not known why that is.
No, it's not clear, but it is really one of the intensely researched areas right now, because we may be able to find out an answer to two very important questions in medicine, whether it is, what are the factors that are causing us to have cancer, right? And if obesity becomes a factor, we will learn, but at the same time, it will give us clues of obesity itself and how to treat it as well. So it's a very important area of research right now.
All right, so now going back to our ladies, Katrina and Samantha. So they're going to be with us for this cycle. So
absolutely.
And I came up with the names last night, and I don't know why. So now, Katrina at BMI 47 and Samantha BMI 42. 6 months from now, would I be like 40% from where I was in terms of my BMI? What should I expect if I was following everything that you told me to, and just showing up for my appointments, doing my daily exercises? What would be the resolution for me in terms of weight loss? So
at 6 months, actually a fair amount of the weight loss will have happened, right? Because a lot of the weight loss happens very early after the surgery. As I said, the first 4 weeks, we talked about anywhere between 10 to 30 pounds to 40 pounds or 50 pounds, depending on where the weight had started first. After that, we would expect anywhere between 2 to 4 pounds weight loss every week, right? So you can stretch that to 6 months and you can see how much more weight they would lose. So generally after gastric bypass, we would see a weight loss of about 75% of the excess weight. And to quantify that, what does that mean? For instance, if a person has started by being about 100 pounds over their ideal body weight, after gastric bypass, we would want them on average to lose at least 75 pounds of that. So if they were supposed to be 150 as their ideal body weight, but now when they come to us, they are 250, right? 100 pounds over. Well, by the time they finish that first year, we would expect them to be at 175 pounds, right? Which means they are only 25 pounds short of getting to that ideal body weight. For gastric sleeve, it's a little bit lower at 65% of their excess body weight. This would be the numbers that we generally see. But from my point of view as a bariatric surgeon, what would I consider success in the long term? A year, 2 years, 3 years, 5 years later. Success is defined in bariatric surgery as maintaining at least 50% of their excess weight being lost, right? So if it means that if a person was 100 pounds over their ideal body weight, and if that at the end that person has maintained a 50-pound weight loss, that means they're at that 50% mark. That's how we define success. Obviously, if they are below that level, then they are short of the goals that we want them to be. If they are above, obviously they're doing well. But there is another factor that is important for us as bariatric surgeons, Kemal, because as you mentioned before, we're not looking purely at the weight of the person. We're looking at the burden of the diseases that are associated with the weight as well. So if that person is taking less medication for blood pressure, if that person is taking less medication for diabetes, if that person doesn't have sleep apnea any longer, if that person has much less joint pain at the end, if they have much less headache, If their mental status is much improved, they are happier about themselves, they are more confident, and maybe not taking antidepressants at the end. That is success, Kemal, regardless of where we are with the weight, obviously.
Well, no, absolutely it is. Last night's presentation was interesting because, having a non-surgical physician here exactly saw some of the challenges that we are having, because everyone is kind of like, I'm okay to say this, that people look at it, well, they are the bariatric program, so they want everyone to have a bariatric surgery. Well, that is correct, except that everyone who fits in the criteria of bariatric surgery group. So if someone is morbidly obese, yes, we do want them to have a surgery. Well, we happen to be benefiting from that. That's beside the point, because we are looking at it, who's benefiting from this long term as a patient. Someone's life changing, someone's life becoming longer, and that person, in the case of that person, is impacting their family, their loved ones, their friends. So it's impacting a big group of people. So yes, we benefit from that financially, so be it. But society is benefiting from that. But when we hear this from a non-surgical person, physician, then you understand that these are issues that everyone is going through. Now, why would we prevent someone who's able to lose 75% of their excess weight in 6 months? I mean, that's a big deal. And that's what we are trying to do here. Of course, when you are doing this, one of the again, most important thing is becoming doing this in a place where you can trust, you can see what the reputation is, you can see how many times we have done this, you can see what the nursing staff, the knowledge of those nurses are. Yesterday I was reading this article. I think it was Warren Buffett. He was talking about like surgery centers, why they are going to be more successful, especially like surgery centers like us. When we have specialties, we become experts in that. So no one is doing the bariatric better than we do. No one is doing the colorectal cases, colonoscopies more efficient than we do. Same thing with some of the general surgery cases, because that's all we do. So if we were doing other cases, and if we had like 7, 8, 10 other specialties, then we wouldn't be as good, and we wouldn't be talking about bariatrics today, perhaps. So that is one of the big advantages that we have to offer, and that's what we are sharing here. So hopefully this is touching someone's lives, and it is helping someone in the future, or someone who's already part of the program. They can learn from what we are discussing. Dr. Erkan, thank you so much. Anything you would like to add before?
No, I think we've said it, Kemal. I mean, we are, specialists, but we're also passionate, for what we do. We have a passion really that is driven by the benefits we see on our patients. When you see a patient that comes back to you, 6 months, 8 months, a year after surgery, and they ask you, can you clear me to go back to work? I don't want to be in disability anymore. I mean, what better, satisfaction can you see, where a person is truly liberated, after they've lost substantial amount of weight and they are a healthier person, and they want to participate in society as an active participant, as opposed to an onlooker, when life is going by, you know what I'm saying? So that is what makes bariatric surgery such a wonderful area of medicine to be in.
Absolutely. Well, Dr. Erkan, thank you so much for joining me. And so I wasn't 100% for next week, but most likely we'll be back next week.
Thank you.
And it's a Friday, but we'll be most likely back. But until then, please stay safe, and thank you for being with us. Right.
Thank you. Thank you. Have a nice weekend, everybody. Bye.
Oh, you know what, Dr. One thing before I leave, Nurses Week Today, this morning I got up and then I asked our marketing team to prepare something for me, and then and so this is what happened. So it is it's the Nurses Week, so they are actually greatest assets for our organizations, for what we are doing, for us to be able to do this. It won't be happening without their support. And
Absolutely.
if they are not able to take care of our patients so well, we won't be able to do these types of activities, and we won't be able to be proud of our patient care. And we do want to thank our nurses and happy Nurses Week.
Yeah, I concur with that completely, Kemal. Absolutely.
Thank you. Bye-bye.